Pallister-Hall Syndrome, or PHS, is a rare genetic disorder with highly variable presentations caused by mutations in the GLI3 gene. This gene plays a key role in the developmental processes of various organs, and the syndrome follows an autosomal dominant inheritance pattern. However, many cases arise from de novo mutations. One of the hallmark features of Pallister-Hall syndrome is the bifid epiglottis, a congenital anomaly where the epiglottis is split into two lobes. While a bifid epiglottis can occur in isolation, its presence is highly indicative of PHS, especially when seen alongside other features. PHS has a broad spectrum of clinical manifestations. Alongside the bifid epiglottis, patients may present with hypopituitarism, a condition where the pituitary gland does not produce sufficient hormones. This can lead to symptoms such as growth retardation, adrenal insufficiency, or delayed puberty. Early identification of hypopituitarism is crucial for initiating appropriate hormone replacement therapy to ensure normal development. Another significant feature is imperforate anus, a malformation where the anus is either absent or improperly developed. This condition requires surgical intervention early in life to establish a functional bowel pathway and prevent complications like bowel obstruction or severe constipation. Management of imperforate anus often involves staged surgeries, including the creation of a colostomy, followed by anaplasty to create a new anus. Postoperative care focuses on maintaining bowel function and preventing infections. The bifid epiglottis, as seen in some patients, can impact airway management. This split or cleft in the epiglottis can alter normal airflow, potentially leading to breathing difficulties, swallowing challenges, or an increased risk of aspiration. However, many cases of bifid epiglottis and PHS are asymptomatic and might be detected incidentally during endoscopic examinations. Diagnosis of PHS requires a combination of genetic testing to identify mutations in the GLI3 gene and clinical assessment. Imaging techniques like MRI are used to detect hypothalamic hamartomas, while endoscopy is crucial for visualizing the bifid epiglottis and evaluating its impact on the airway. Evaluations for hypopituitarism include hormonal assays to assess pituitary function. Management of Pallister-Hall syndrome requires a multidisciplinary approach. Hypopituitarism is managed through hormone replacement therapy, such as cortisol, thyroid hormones, and growth hormone, depending on the deficiencies identified. For patients with a symptomatic bifid epiglottis, monitoring is often sufficient, but surgical correction may be considered if significant airway obstruction or feeding issues are present. Surgical intervention for imperforate anus is critical in the early years to ensure bowel functionality. A bifid epiglottis should prompt consideration of underlying genetic syndromes like Pallister-Hall. Monitor for hypopituitarism symptoms and address them with appropriate hormonal therapies. Early surgical intervention is crucial for conditions like imperforate anus to ensure normal development. Genetic counseling is vital for families due to the inheritable nature of PHS. Understanding Pallister-Hall syndrome's complex presentation, from endocrine issues like hypopituitarism to structural anomalies like bifid epiglottis and imperforate anus, is essential for advanced medical practice. Early diagnosis and targeted intervention can significantly improve patient outcomes.